brief. We are going to send. I'm going to give a brief a show of the flyer. I think the flyer is going to be sent out to you. The flyers are very condensed. So when this was presented to me, and I've done these kind of rapid 15-minute, 20-minute talks, and usually I present a flyer to say, what can I give you? What can we do real quick? And I'll give a quick visual of that because it will review what we're going to be talking about, and then I'll go to the presentation. This is about strategies for behavioral nutrition, cognitive therapy. We're not going to talk about nutrition, but this really is a systemic model. And for me, coming from a family therapy standpoint, so I think structural, strategic, communication model, psychodynamic, cognitive, behavioral, experiential, whether you want to do satire or not, all the different types of therapy. So I'm very much a therapist first. And we're going to be talking today about assessing family structure and that idea. What are our goals for some of those things? This is probably the foundation, and it's often skipped. And it's unfortunate because the family is the foundation for most, I think most therapeutic treatment with children. As we know from IHBT, when we don't have family systems, and as someone who has worked, in the foster care system and residential system, not having that family structure can contribute to the success or lack of success. Phase 2, negotiating new relationship patterns, because even though we talk about food and such, really what we're really talking about is a relationship, but the relationship to self and the relationship to the family, and addressing distortions, recognizing negative cognitions, and finally working on really adolescent issues, parent relationships, modeling problem solving. I am a chain analysis person since I direct the DBT program and I do TFCBT. I don't do much EMDR anymore. Talking about negative family changes, cognitive behavioral change analysis, chronic individual stressors, psychosocial stressors, distortions, talking about patterns that link with each other, because that's what all of us do. We see these interacting patterns, and we'll go into this to a more extent. And then I've kind of put some summaries of Maudsley structural family therapy, nutritional therapy, cognitive behavioral therapy, and some references there at the end. Now I have to figure out how to do my quick stop share and go back to sharing with my full screen. Okay, so that will be sent out to you. Okay, and this should be it. Let me know if there are any problems seeing that. Can everyone see it? Okay, good. So again, this is brief, so we're gonna kind of push through in some ways because I want to leave time. I left a time if you guys want. I do have a case example, and we'll get to the end that if you want to go through, I can show some of the integration that happens. This was a particular residential case with type 1 diabetic who is bulimic, purging. The wonderful thing about being diabetic is you don't take your insulin, you don't absorb any of the carbs, which could feel like a wonderful thing for most, but it can cause some problems. But we call that diabulimia, and that happens. So let me go up here. So talking about some of those phases we talked about, again, what often gets missed in a lot of our treatment, regardless of whether it's eating disorders or not, assessing family structure in the family-based treatment, because it is the foundation for any improvement. Negotiating new relationship patterns, this has to happen before you can examine new relationships for the child to examine themselves with food or with themselves. And then finally addressing some of the normal adolescent issues and termination. Where do we go to traditional family therapy? So there's a lot of different eating disorders. The majority, ruminations, avoidant, binge eating. The reality is most of us deal with like anorexia or bulimia. I mean, that's really what it is. And I'm not here to give a DSM diagnosis. That's just to kind of bring up some of those things. Some of us who grew up in the 70s and 80s remember this. Unfortunately, thankfully we've moved away, but it was a very real thing. And the thin hair, the dry hair, these fast pulses, constipation, dry skin, lightheadedness, having brittle nails, that people would say, why would you ever do this? It's not intended, but it is some of the consequences. I'm not going to, I don't want to practice psychiatry. We're not going to go into this. We want to go into family systems. But these kids present with dizziness, headaches, poor responsiveness, their sleep is all over the place, they don't heal, their menstrual cycles are all over the place, IQ dysfunction, health status is all over the place. So it starts to have this domino effect, not just on their health. It affects their school, it affects their socialization, it affects their relatedness to other people at a time when they're incredibly vulnerable about their relatedness to others. It is a systemic issue. So as I think about phases of care, we're going to think about assessing family structure and refeeding, negotiating patterns, and then adolescent issues. Really, my focus is going to be primarily about this phase one, a little bit less on phase two. So a little bit about the research. What I think is incredibly frustrating for all of us, because I like working with people who work at this interface. I was just having a conversation with my clinical coordinator, Wendy Cleveland, who we were all talking about like evidence-based treatment and quality outcomes. And I said, the majority of research is based upon a very, very narrow population that is very perfect for research. And I said, none of our patients fit any of those things. We have to deal with the messy stuff. When we talk about eating disorder research, most of the information is based upon people who have only been ill for less than 2 years. It was really just anorexics. It has a very limited information, and we generalize this to these broad populations that we end up having to deal with, and it doesn't always work. The family is a resource. Family-based treatment, we don't make assumptions about family structure or process as a contributor to eating disorders. We do recognize patterns, though, in rigid sequences that can be interfering. We look at what is the best type of evidence. So hopefully all of us come from different family systems. I come from rural areas. And I can tell you, we had a regular mealtime and structure, and it was a meal as a family. And family was about sharing, and it was about communication. And it wasn't just about a meal; it was about communicating who you were and your day. And it was an involvement in the process. It was about teaching skills. It wasn't just about setting a table. It was about teaching a role and developing a role of you can do this part as a small child and you can do this as a bigger person. And that's often missed. There are people who use Grubhub and use other things, and families don't do food prep anymore. And we don't always have time because our work takes us away from that. But what they're really taking away from us is communication. There's, what involvement do we have in food prep? I know adults that just can't cook. They don't know how to cook. And I say, get yourself a home meal kit. It will walk you through. It's very important. And it's meditative. For me, it's meditation to cook. How do you get portion selection? For those of us who are in our late 50s, portions used to be really small. Now you go out to eat and the plate is 2 times the size of my head. And that's being projected onto us that we should be able to eat this. Negative family, there's abnormal timing. They avoid family meals. There's specific food avoidance, and they compensate. Again, runway models. There's calorie counting. We all know these kind of things. I don't want to focus on this. The most important thing is, from a behavioral standpoint, behaviors are meant to compensate or undo. I always say, I missed your birthday. I can be like, oh, I'm sorry. Can I make it up to you? Can I take you out for lunch? Well, I can't make up for missing your birthday. But what I'm trying to do is I'm trying to undo the guilt in myself. But really, it's just a mental mathematics. And they want to relieve guilt associated with eating, which may have joy. And sometimes we eat to the point of discomfort or anxiety, then we purge. This is the most important part: family. What kind of holding or containment can we do? I'm very much a Kleinian, Bionian person, so I believe in holding and containing. And I talk about emotional bladders and to say, how full is your emotional bladder? Because once you let it out, it's hard to stop it. So symptoms occur when there's a power struggle. And usually when we look at families, there's inadequate hierarchy or conflict between individuals, or even a detouring triangulation. We see a power struggle within a parent couple, but the child becomes the detouring triangle, meaning the tension is displaced to the child, and the child is being asked to work out a tension that they don't quite understand or aren't responsible for. This morning, I gave an example of a 4-year-old who said that his parents are getting divorced, and I said, why? And he says, because they yell all the time. And I said, what do they yell about? And they said, I don't eat my green beans. And everyone usually laughs, but the attuned people really see, here's a 4-year-old who says, it's my job to eat my green beans, and it's my fault that my parents are breaking up. And children, even adolescents, misinterpret what is going on within the family system, but they're still the recipients of it. So symptoms reflect specific behavioral interactions. Symptoms are metaphors for the larger organization. I always say the child is the barometer of the family. They reveal the pressures in the family system because they're the most vulnerable. They have the least resources. Individuals or families have psychosocial resources. They do, if we give them the opportunity. If we can give them the opportunity to correct and build those things on their own. Small incremental shifts and behavioral sequences can reestablish appropriate hierarchies, reduce conflict, and abate power struggles. And that's everything that we do in our work. We are about incremental shifts. Where is the point where we can put the most energy for the biggest bang for the buck? And can we reestablish an appropriate hierarchy so that someone isn't being asked to do something developmentally appropriate? Can we reduce the conflict and identify what the conflict is and abate the power struggles? Insight is not required to solve these problems. I'm an insight-oriented psychoanalytic person, and if I can solve something without insight, I think that's great. Sometimes we just need to solve the problem. Problems in the identified patient can't be expected to change unless we change the family system, and we all know that there's incredible resistance to that. Case after case after case. Control is not defined as the manipulation of another person. Oh, even though it's perceived as that, it's like, you're doing this to me, you're making me, or you're asking me. We would say, and the other talk I could have given was interpersonal role disputes, is to say, but I shouldn't have to parent you at this age. I say to kids, I say, we do for our children, we do with our children. If you guys are from Cleveland, trained at Hannah Perkins, Cleveland Psychoanalytic. And finally, admire from a distance. So there's a lot of the missing the doing with. Sometimes we do for our children, and then we expect them to do it on their own. And there are times we need to do with. So oftentimes we talk about a sick role. And so parents and other people can feel like, you're asking me to do things, you're controlling me. And it's not about control. Oftentimes we do Socratic questionings. We try to reestablish the hierarchy. We want to figure out what's going on in the family system by inquiring about this. I always say, but I just want you to be curious. Let's take the judgment out. In an analysis, I say, I just want you to be curious about yourself and be interested in what's going on in your body and in your mind. Parents are charged with refeeding, and we empower parents with affirmation. Parenting is hard. They need support. And we want to separate sometimes the eating disorder from the patient. Some people do this and say it's the eating disorder. Unfortunately, I work with some patients who are like, yeah, it's my alter who does this. I'm like, okay, let's own this part back. We do want to create appropriate levels of anxiety in parents, and we'll talk about this a little bit. So when we do family structure, we identify the problem. We assess behavioral sequences. We alter those sequences. This is standard strategic or systemic family therapy, and address issues of compliance. For those of you who haven't done DBT, this is a behavior chain, and that's what we're leading into. What makes me vulnerable? What are the triggers? I openly tell people when I fall in yoga, sometimes there isn't a trigger. It's just, I just couldn't hold that balance for that long. And it's the same thing emotionally. That, can I feel it in my body? Can I understand the urge? What am I expressing? Are you doing an emotional pee-pee dance, is the way I put it, is to say, are your parents attuned enough that they can pick up on the emotional pee-pee dance? Or are they ignoring it and you're expected to do it on your own? When we look at family systems, we're consultants, we're non-authoritarian. We only modify the problems that make the refeeding difficult. Don't change everything. It's too much. I'm big about the family meals. I think it's about communication. Having come from communication model and Tavistock model, it's an opportunity for therapeutic coaching because everyone needs help. We want to examine the impact on the family system, assess the family structure, the conflicts, the coalitions, the processes of conflict resolution. Oftentimes we take minor conflicts about homework and we want to apply it to suicide or to an eating disorder. And to say, yeah, Dad, you can't hang in the back until mom is exhausted. That doesn't work. We need to change the sequence within the family system. And actually assessing likelihoods of parents' ability. Even this morning in IHBT, we were talking about like a parent that wasn't fulfilling something, and I could hear the therapist's frustration. And I always interpret that as an emotion being put into the therapist. It may be a passive enactment, but the parent is also telling you, I can't do this. You're asking me to do something, and it's too big of a cost for me. And to meet it with empathy. We want to give them success, and we want to keep the focus on assisting parents. So stratification, I think for all of us who work in these kind of models, we stratify care. Inpatient is just about stabilization. This is an example where somebody once we got them about 60 pounds, we did a 30-minute lunch with the guidance counselor and making sure they ate 100% of the meals. We did some blind weight, but at least they were able to go to school. Once they had some stable blood pressure, guess what? You get to have much lunch with a friend. We incentivize, but you're not allowed to exercise. But once you get up another 10 pounds, it's, hey, you get to be able to go to the cafeteria, you get to be able to exercise, and we stratify those things. Always work at the level of care where you're at. Meet the patient where they are presently at. Assessing family structure, engaging the family. What's the impact? I've reviewed some of these. What's the likelihood? Giving those success. So this is a little bit review. Another aspect of models, it's like, yeah, we're all supposed to look the same. Even to a young man who I saw the other night, he's like, well, I just don't think I'm that good looking. And he's probably got 2% body fat. He has no acne. He's got an ACT of 35, and he's like, no one wants me. And it's because in his mind, he has an image that I don't fit the image of what I think I should be. And all of us carry those images. We may not like to acknowledge it, but we do. And we're treated by consumerism to look and to want the same, to be these things. Negotiating new patterns. Parents have to take over these functions just as we would for any other developmental function. You cut your child's food when they didn't know how to cut it. You dress them, and then occasionally you let them put the wrong shoes on, or you say, well, you're 4 and that outfit doesn't work, but that's okay. We're going to let you go. You're very proud of how you look today. And we're going to help you in some ways. So do for, do with, and then admire when they get it right. Gradually, we return that responsibility when they show they're capable and it doesn't cause distress. Explore the relationship with their adolescent normal development, that it isn't just about an eating disorder. Eating disorders are say, I don't have control in this portion of my life. I can control this. And to address those distortions. Recognize the cognitions. So CBT, we all know CBT is, it's emotion. Our thoughts are linked to our emotions, which affect our behavior. I have to throw some things in here. Ideas are sexy too. Even this might be called kind of a orthorexia, that we all expect that we're supposed to be all muscular and 2% body fat, and that's just not real. And we're not all Einstein. Although I would get the E equals MC squared if I looked like that and thought like that. So we're talking about overvaluation of shape and their control, overvaluation of achieving and achievement, and overvaluation of control over eating. That's what we're really talking about. And I'm going to put this in a sequence. I'm also a schema therapist. If people who don't know schema, that's to say that, we, as an attachment-based person, we grow up with some working models. And I say I had one child who went through about 30 different foster placements before the age of 5. And he had some schema like mom's boyfriends beat me if I say things, if I talk. if I talk back. And so apparently anger isn't accepted in these family systems, or people love me and I've been with them for a week and they want me to call them mommy, but then next week I'm at a different house. And they learn schema of like to say, I need to comply if I am to stay loved. But we keep those working models far beyond when they're needed, and they become unconscious. I always say the software becomes hardware. You want to load your new Microsoft onto a Windows 98, for those of you who were born before 1998, but it just doesn't work. It won't load. So they are these memories, cognitions, and sensations. They really are body sensations. They're feelings. Just like if you ever saw the movie Ratatouille, and the chef eats the ratatouille, or the critic eats the ratatouille, and he's taken back to when he was in the Parisian fields. Body experiences are physical. Freud said we first have a body ego. We know about ourselves by our body, and we superimpose these kind of old rules on new experiences. So we think about triggering events leads to overvaluation of shape and weight, and that's the thought. So the feeling leads to a thought, and that leads to dieting, binge eating, and compensatory behaviors. So this is the beginning. Now, this is a behavior chain. Many people have seen it. What are the events? What are the beliefs? What are the assumptions? What are the triggers, thoughts, feelings, behavior? I always say, I don't need you to catch any of them. I just need you to catch one of them, because if you can catch one of them, you'll stop the chain. And I'm going to focus on your strengths. Bigorexia. We don't think of these people as having eating disorders. I even got a shredded thing with PowerPoint because they're all shredded. But these people look in the mirror and they think they're too small. They just think they're not big enough. So that is a real phenomenon. So we overvalue achieving and achievement. We pursue these personally demanding standards. All of us I work for an institution. It has very high standards. We must do better, be better, measure better outcomes. And so it's like, we're doing great this year. And then the directors say, we want to reset the standards. And it's like, great, that's great. And we have to communicate how stressed we are. We get preoccupied with thoughts about our performance. We get performance checking, and there's a tendency to look at deficiencies. And we marginalize other areas of our life. We put more energy into our work than we do our personal lives. And so how does this link? Well, I've linked the two together now. The overvaluation of shape and weight is impacted by the overvaluation of achieving and achievement, which is also integrated by the demanding standards and the preoccupation with performance and deficiencies. So these feedback. Barbie, Malibu Barbie, Malibu Anna. Overvaluation of control. So there's dietary constraint, which leads to check control over eating. You can reset standards if goals are achieved. We get very preoccupied with the thoughts, and marginalization. Now, we could substitute eating, and we could say billing, we could say productivity. In my field, we could say revenue value units. It all becomes the same thing. And so I look at all self-harm behaviors. Even though I'm talking about eating disorders, I think all self-harms are the same way. And I don't judge one or the other, whether alcohol, eating, productivity, muscle, what have you. It's all the same thing. And these can feed in as well into these over controls. We then link these in a broader context. We have a core low self-esteem, unconditional pervasive self-worth. My young man who went to USC, ACT of 35, graduating from OSU now, feels worthless. He's got 2% body fat, works out every day. But he's like, yeah, but my parents are doctors. My dad went to the military. I can never be in the military. My brother's a graduate student who's in touring Europe. And I was like, okay, he just keeps knocking himself down. And he says, I just keep failing. And I'm like, there's nothing I can tell him to say he's not failing, because he feels failing. But over this cognition that we have on the outside, underlying this in the feeling state and action, this is a reciprocal feedback relationship of this overvaluation of shape and weight, the strict dying, binge eating, and compensatory behavior. And again, it's not just eating, but we have lots of compensations. Finally, getting to adolescent issues, establish an adolescent-parent relationship, which seems really simple.
Yeah, I
but
do.
it's
Thank you.
but it's also saying that I'm not your friend. There was a beautiful quote that I was giving to my psychotherapy class the other day. It was talking about an analyst and the analyst's husband when their daughters were playing dress up, and the 12-year-old came in, and they were playing dress up, and the 12-year-old had a black dress with a slit up the thigh, lipstick, the fishnet stockings, heels, everything, and came into the room. And they came in with the analyst, which is female, and her husband, and the husband was like, and the analyst wife was also like, and then the 12-year-old daughter left the room crying, because she's like, oh my God, you think I'm horrible, you think all these kind of things. In this case, the father had to went back in, and had to explain. And the analyst said to her husband, he said, "What did you say to calm her down?" And he said, "Well, I actually just told her the truth. I said, I said, I was struck. I've never seen you that way before. I like it. I like the way you look, but honey, this is something new for me, and I'm not used to seeing you this way, but I'm going to get used to it. And I like it." And the analyst kind of said, she said, "What did she say?" She said, "Well, she didn't say anything, but she did smile the brightest smile." And so it was an important aspect of where there was almost a violation of this relationship. The parents were like, I'm not ready for this. And they had a moment of how do I reestablish that my daughter needs me to both reflect that I admire her for her body. It also scares me because I didn't realize that you're becoming a young woman, and it creates feelings in me that are my feelings, because there's attraction and other things. And it also says, I have to let this go because you are a beautiful person, and someone is going to love you, and it's not going to be me. And I can let this go. And that's a very hard thing for parents, to be able to hold on to all of those feelings and relationships. So when I say adolescent-parent relationship, it's really hard. And model problem-solving strategies regarding these developmental issues, such as like that body changes, sexuality, all this stuff is coming in. And addressing these dynamic features, such as these things, and to say, do I feel comfortable with this? Do I feel comfortable being sexual? Do I feel comfortable with my body, which is changing and I don't want it to change? And why do I have to have a period for the next 30, 35 years? And then they said there's menopause, and then they said everything's horrible. I don't want this. And then finally, further treatment on the individual and family structural dynamics. And then termination of treatment. And I'm going to stop there, just because I want to kind of bring those things over before, if you want to do a case, I can, but to kind of bring in some of the easy part and the complexity. I think I think family system work is incredible. I always say to people, if they're getting bored with individual therapy, I say, do some family work. Do some work. You'll never be bored again.